Thank you all for being here today. I know that all of you are balancing many competing demands on your time. I'm Debra Kaysen. I'm a clinical psychologist with clinical and research expertise in the treatment of traumatic stress. This year has been a challenge for most, if not all of us. For some, it's been an exacerbation of existing stressors around economics, health concerns, parenting, caretaking, or work. For others, it was a whole new slew of challenges. I'll be focusing today on discussing the challenges for healthcare workers, but the information should apply broadly, regardless of the particular challenges you may have faced over this past year. The scope of the COVID-19 pandemic is unprecedented, both in terms of global impact and duration. As we all know, the U.S. has been one of the hotspots, and cases have been high in California. Healthcare workers are one of the groups that's most at risk for experiencing the mental health effects from the pandemic. Now, we haven't been flying entirely blind. Research from the SARS, MERS, and Ebola outbreaks indicated that healthcare workers and recovered patients have been at particularly high risk for depression, anxiety, and PTSD, both during and in the aftermath of those outbreaks. Among healthcare workers, those who work directly with SARS-positive or MERS-positive patients are among those most likely to experience mental health symptoms, particularly in the months and years that followed the outbreak. Focusing specifically now on COVID-19, what we see are among healthcare workers, depression, anxiety, and PTSD symptoms have been particularly high, with about half of healthcare workers reporting symptoms of depression, a little less than half reporting symptoms of anxiety, and about 70% reporting symptoms of PTSD. Now, this is research that was conducted during the first wave of COVID cases in China. And was most particularly found among those working directly with COVID-positive patients. When we look more closely at those experiencing clinical symptoms, the rates are much lower, but they still represent a sizable portion of that healthcare workforce. Women, nursing, staff, and those with more direct exposure to COVID patients are most at risk. In a study of 906 healthcare providers in Singapore and India, with about a 30% physician enrollment rate, anxiety was documented in about 15%, depression in about 10%, and stress in about 5% of the study participants, which is actually fairly consistent with the numbers that we were seeing out of China. As COVID-19 entered the United States, healthcare workers faced uncertainty in their work environment, financial stability, job stability in their home environment. Healthcare systems were not prepared to deal with the pandemic, and healthcare workers dealt with shortages of recommended supplies. Healthcare systems also redeployed and furloughed healthcare workers. Private practices were impacted as clinic visits fell or were replaced with telemedicine. Frontline healthcare workers experienced feelings of social isolation, stress related to employment changes, deaths of colleagues, and the fear of exposing family members to pathogens. All of these are contributors to distress. I also want to highlight media coverage, in particular because when we look at the global literature on large-scale traumas, for example, the research coming out of the 9/11 event, what we find is the more time that people spend consuming media about the event, the more their risk of depression, anxiety, and PTSD over time. So this is one of those things as we notice what can we change, what can we control. Our consumption of media coverage is one place where we can make changes and help buffer ourselves from distress. Now, the other thing I want to highlight is that none of this has been happening on its own. All of these events have been happening within a context of natural disasters and social uprising, along with what may be happening in our own personal lives. When we look at the impact of acute stressors, what we see is that most people will experience strong emotions and physical reactions to these types of events. This can include things like intrusive reactions to thoughts, images, dreams, or emotional or physical reactions to reminders of the event. Avoidance responses. This can look like avoiding talking about the event, avoiding having feelings about it, or avoiding reminders of the event. Pushing through can also be a form of avoidance response, as can working too hard or too many hours. People also may experience arousal, such as looking for danger, being easily startled or jumpy, feeling irritable or cranky, or having outbursts of anger or tears, having trouble sleeping or concentrating. In a context like COVID, it can also include monitoring yourself or other people for physical signs of infection. Grief is extremely common with these types of events. This can include sadness, anger, guilt, regret, missing or longing for the person who died, or having dreams of seeing them again. Grief can also include grief around the losses or around the way things were before this event. With traumatic grief, the person may focus on the circumstances, so how the death could have been prevented or who might have been at fault, and this can make it difficult to adjust to the death. There also might be guilt over potential transmission of the virus to family members, or over difficult medical decisions, or moral distress, over lower work efficiency, or over mistakes. All of these responses are normal, especially in the early aftermath of a stressor. But if the responses continue more than 2 months after a stressor has ended, or they impair functioning, that may be a sign that it's time to get additional supports. Now, with all of this, it can be easy with this backdrop to lose hope and to feel like these reactions won't end. Although this is a difficult time for many people, these initial and normal responses to a severe stressor are going to improve over time because people generally are resilient. Most people do recover even from severe stressors naturally over time. The same way one's body might recover after an acute injury. We think about this as resilience, or the process of adapting well in the face of adversity. Now, when we talk about resilience, it's often spoken about as if it's extraordinary. However, what we find is that resilience is actually both ordinary and common. Another common misperception is that resilience is a trait, something you've either got or you don't have. However, it is actually a set of behaviors and responses that can be learned and acquired. The last myth about resilience is that it means that someone is not suffering, that it is the absence of difficulty or distress. But instead, emotional pain and sadness are common in people who've suffered major adversity or trauma in their lives. Instead, what resilience is it's the ability to bounce back from difficult experiences. Now, sometimes during difficult times, we may ask whether resilience or recovery are even possible. However, based on my own research, I would say that it is even in the most stressful of circumstances. These are findings from a research trial of the use of a cognitive therapy to treat PTSD among sexual assault survivors in the Democratic Republic of Congo. We compared sites with ongoing levels of violence and trauma with those with lower levels. What we found in this analysis was that women's symptoms improved over the course of a short cognitive therapy, even in places with high levels of ongoing violence. So why is that relevant here and now? We are in a time of strife and uncertainty, but these findings suggest that with the right tools, we too can reduce distress and promote resilience. So let's talk a little bit about how. So I want to start with talking about psychological first aid. One of the interventions that people have tried in addressing acute trauma responses is a modular program called psychological first aid. And in the initial aftermath of COVID-19, in those first waves, many healthcare systems implemented brief interventions like psychological first aid. Psychological first aid was developed to reduce distress and build resilience following events like natural disasters or other mass traumas. It provides a framework to address the immediate needs of those populations. It can be readily implemented without mental health specialists. We receive funding to conduct a national survey of medical centers and large healthcare organizations to determine who offered psychological first aid, and for those who did, how it was implemented. We found that 40% of healthcare systems and academic medical centers offered psychological first aid, and 40% offered some other kind of health or wellness program in response to COVID-19 for their healthcare workforce. This suggests that many healthcare programs were trying to figure out best practices to build resilience in their workforce. However, psychological first aid was truly developed as an intervention for the first few days after an event. So this does beg the question of what to do with a stressor that comes in waves and that has lasted now for more than a year. Part of my current work is to develop a scalable approach that can help address recovery for those who might need a bit more support, given that our current mental health workforce and infrastructure may not be able to accommodate the increased need for services following stressors from COVID-19. So I want to talk a little bit about the groups that we tried at Stanford. This was an effort by the Department of Psychiatry from volunteers who responded early following the pandemic when we were first anticipating the wave in cases. Volunteers stepped up to organize what we called Connect and Recharge groups, specifically for the Stanford workforce. So we had groups specifically targeted towards physicians, towards staff, and towards trainees. What we found was an initial expression of interest in these groups that actually outstripped our ability to respond to the need. We developed a model for rolling out groups that could be delivered via Zoom. And what we found is that we were able to meet the need for the initial request for services. We also found that over time, the requests for those groups gradually declined. Now, I do want to add that all of this was occurring when we were anticipating cases, but this area had not yet gotten hit by its large wave of COVID-19 positive patients. So what we found was a drop-off in interest, suggesting that psychological first aid has a place, but it may not be as good for something that is coming in a chronic fashion once we get past the first wave of cases. So I want to talk about our next project. What we think when we look at the literature on how do you respond to acute stressors, what we see is psychological first aid was really developed for those first 24 to 72 hours after an event. And the goal of that is to promote resilience and to help establish safety and stabilization. In the days to weeks after a trauma, what we're focused on there is how to build resilience in a more ongoing way. Once people have exited those first few weeks, then we're really looking at a recovery period where people may need a slightly higher standard of care. And so psychological first aid and that approach may be a better fit for short-term acute events, but for a chronic emergency, we may need a slightly different approach. So let me talk to you about that. So this is a project that was funded by a generous donor, and based on that funding, we're developing a web-based product to try to bring tools to busy healthcare workers when they need them and where they need them in an accessible and confidential platform. This project is going to use regular assessments of levels of distress and symptoms to suggest evidence-based tools and to tailor those tools to the needs of the person who is asking for them. The idea is to create something that's both engaging and rewarding, is effective, is scalable, and is sustainable. As we gather information about what aspects of the program may be more or less effective, we'll be able to refine the tools that we offer. We're expecting to launch August 2nd with our initial product. We're initially working on reducing symptoms of depression, anxiety, and PTSD. And over time, we hope to build in resources to address sleep disturbance and substance use. Now, that doesn't help the people right now who may be suffering. So I want to talk about, for those of you who may be suffering now or needing to build resilience now, here are some suggestions based on my body of work and the research of many others. So one way to promote resilience is to shift how we think and what we do. When we experience a stressor, or even an everyday event, it triggers both an emotional and a physiological response. So one issue is how we talk to ourselves, the story we tell ourselves about what has happened. When our thinking is more rigid, it can lead to more distress. Think about it like that coach we all have in our minds who's offering commentary about what's going on. That coach may be more or less helpful. By shifting the thinking to be more flexible and helpful, it can shift our responses. This is very much like yoga for our brain. So, what you can do to add some flexibility is to ask yourself some questions about the thought. How realistic is the self-talk? What would you tell a friend? What would your kindest self say about this? What realistic information do you have that the thought is true? What are you leaving out? Based on those questions, come up with a new, more flexible, probably more helpful thought and practice it. And that should eventually lead to a shift in emotions. So, for example, if I'm standing here giving this talk to you, and I have the thought, this is the worst talk ever, I'm never going to be invited back to give a talk. It's probably going to make me feel anxious. I'm going to be less likely to say yes to another request. But if I ask myself, what would my kindest self say? What would I say to a friend? I would probably come up with a more balanced thought that's probably more realistic and that's going to decrease that experience of distress. Now, I want to talk about the other piece of the puzzle. What we do also influences how we feel. Often when we become more stressed, we withdraw. We stop doing the things that we value. With COVID-19, some of our old ways of coping or activities that we value may have stopped due to public health and safety concerns. By building activities that we value and that are reinforcing back in, it can improve our mood and foster resilience. Now, it may take some creativity right now to find ways to do these things, but there are big benefits in terms of our mood and our ability to cope. And since thoughts and behavior influence each other, the good news is that if you have a few different avenues to pursue in order to reduce suffering and to build resilience. So, in summary, much of my research has been focused on the treatment of PTSD among survivors of trauma, whether that's sexual assault survivors here or in the Democratic Republic of Congo, torture survivors in Iraq, soldiers who served in the wars in Iraq and Afghanistan, or Native American women recovering from historical trauma. Part of the joy in this body of clinical research is that there is always hope, and for many there is recovery and regrowth. Although we still have much work to do in this field, it also gives me much hope for our ability to be resilient in the face of COVID-19, and for those who need more support to find effective and scalable solutions for recovery. Thank you so much.